Welcome to Critical Matters, a sound podcast covering a broad range of topics related to the practice of intensive care medicine. Sound provides comprehensive critical care programs to hospitals across the country. To learn more about our programs and career opportunities, visit www.soundphysicians.com. And now, your host, Dr. Sergio Zanotti.
In today's episode of Critical Matters, we will discuss the management of invasive candidiasis in critically ill patients. Invasive candidiasis is frequent in critically ill patients and is associated with high mortality and morbidity. Our guest is Dr. Max Adelman, a practicing critical care and infectious disease physician at Houston Methodist Hospital. Dr. Adelman is an assistant professor of medicine at Weill Cornell Medical College, and his clinical interests include bacteremia, hospital-acquired infections, immunocompromised hosts, multidrug-resistant organisms, and septic shock. Max, welcome back to Critical Matters.
Thanks so much, Sergio. Thanks a lot for having me back.
Well, it's been a while, and we were commenting before we started recording that we did an episode that I'll link in the show notes on C. diff back in the height of the pandemic, but things have changed. You have moved. You're much closer to where I live now. But the topic of candida infections in the ICU, as somebody who wears two hats, the infectious disease and the critical care hat, I'm sure is very interesting and important for you. But why should our audience be interested in this topic?
Yeah, much like C. diff, Candida is a really important infection for both ID and critical care docs alike. I think critical care practitioners and physicians really need to be up to speed on candidemia because it's a really prevalent infection in the ICU. Really, a lot of our ICU interventions are specific risk factors for candidemia, so it's particularly prevalent in the ICU, and it can cause serious morbidity and mortality among the patients who get it. And these folks are usually the folks who are already at really high risk of poor outcomes. So it's really prevalent. It affects our most vulnerable patients in the ICU, and it can cause really bad outcomes.
Perfect. One of my observations with Candida has been that when we talk about it, usually it's irrelevant. And when we're not talking about it, it's when it causes problems, right? People tend to over worry about things that are just colonization, but miss the real infections. What are the types of Candida infection that we're going to talk about today that are relevant to the ICU? And could you provide an overview on the epidemiology of these infections in the ICU?
Yeah, absolutely. So that's an excellent point. I think by talking about the times where we often see Candida and it doesn't really matter, we know that Candida can do what we call colonize the respiratory tract and the urine especially, and that means it just kind of lives there but doesn't cause any clinical infection. So if you see it pop up in a urine culture or respiratory culture, you don't really have to worry about it and just know that it's not causing an infection in those sites. On the other hand, if you isolate Candida from what we call a sterile site, then it is considered a clinical infection. So we can break down all of these Candida actual infections are what we call invasive candidiasis. And really we see this show up in two ways. The first is candidemia, which is a Candida bloodstream infection, and the other is deep-seated candidiasis, and that's where we have Candida isolated from a normally sterile place, usually the abdomen. And this form of invasive candidiasis, called intra-abdominal candidiasis, is really prevalent, especially in the surgical ICU. You know, the incidence is a little bit hard to define. It certainly varies depending on the population, but we know that the incidence and associated mortality of candidemia and invasive candidiasis are rising in the past few years. Candida might be the second most common cause of bloodstream infections in the ICU and probably makes up about 20% of ICU-acquired bloodstream infections. So it's pretty prevalent, and it's something we all really need to be thinking about and giving it sort of the respect it deserves because the severity of the infections it can cause.
In terms of Candida species today, could you give us a little bit more and also talk about the importance of C. auris, which is I think they changed the name. I'm just going to call it C. auris today, but that is really emerging as an important pathogen for us.
Yeah, so Sergio, we were talking a little bit about this before, but a lot of the names have changed. I don't want to get into all of the specifics, but if you see something that you're not sure if it's Candida or not pop up in the microbiology report, just put it into Google and you can see if it's one of the new names for Candida. You know, the microbiologists have gotten excited with renaming everything, but clinically, the name changes haven't affect how we clinically take care of these patients, except for probably adding a little more confusion. So Candida albicans has long been the most prevalent species of Candida that we see, and it still is. This one is usually susceptible to the antifungals we use. On the other hand, there are other species such as Candida parapsilosis and Candida glabrata that can be variably resistant to the first-line antifungals, and these have been probably increasing in prevalence over the past 10 or so years, and that's related to more antifungal use likely and more immunocompromised patients who are getting these infections. And then really the big one that we're all worried about is Candida auris. I'm sure everyone has heard about this one by now. It is potentially multi-drug resistant, and it's really worrisome because it really likes to colonize or stick to our medical devices. It's really difficult to clean. So even if you do your normal disinfection of a hospital room, it might stick around, and then it can just sort of get all over the patients and the nurses who are in the room. So it's a big issue for our kind of chronically hospitalized, potentially chronically critically ill patients, because they're really at high risk for getting this infection with Candida auris. And then, as I mentioned, it can be multi-drug resistant, so that can make it more difficult to treat once folks do get it.
What about the pathogenesis of invasive candidiasis? Obviously, there's a basic characteristic of how Candida becomes a problem in our ICU patients. Could you go over that?
Yeah, absolutely. So a lot of Candida species are common and live on all of us. So let's just take Candida albicans as an example. Almost all of us sort of routinely carry Candida albicans in our GI tract and even on our skin. And under normal conditions, this is really kept in check. Probably our gut bacteria do a good job of keeping Candida in its little niche in the GI tract. But then when we're in the ICU, and as I mentioned at the outset, really a lot of things that we do to patients in the ICU are specific risk factors for development of invasive candidiasis or severe Candida infections. So for example, all these patients get antibiotics, which in addition to killing the target bacteria can disrupt the microbiome and allow for Candida to kind of expand in the GI tract. These patients are frequently immunocompromised, which means that the Candida won't be kept in check as well by the immune system. They have GI barrier dysfunction. So Candida can what we call translocate or move across the GI tract. Urinary catheters and central venous catheters allow Candida direct access into normally, we've kind of passed our normal mucosal barriers. So really all of the things that we're doing to ICU patients are putting them at higher risk. But usually it does take some actual disruption of a normal barrier. For example, a central line will allow the Candida that's colonizing the skin to crawl into the bloodstream through the central line. Or if patients have had GI surgery, then the disruption in the normal GI tract can allow Candida to leak from inside the lumen of the GI tract out into the abdomen where it can cause an infection. So that's really how we see it most commonly. The other way patients can get Candida infection is patients who are on chemotherapy or severely neutropenic, and they just have some gut barrier dysfunction and decreased immunity, and then the Candida can again translocate across the GI tract. So really a severe defect in immunity in that last case, or a disruption in the normal mucosal barriers in the case of GI surgery or central venous catheters are really kind of the last step in leading to severe invasive candidiasis.
And I should have mentioned it earlier in the introduction, but Max, you recently published a wonderful review in Chest, and I overall enjoyed reading and learning from it. But one of the things that I really, really liked was your creative use of a figure to talk about risk factors. And usually that's just something people throw on a table, but you did it in a very creative way, I think, that really resonated with me because it really illustrated why our patients are such high risk for these infections. Could we talk about risk factors in critically ill patients for Candida infections?
Yeah, absolutely. Thank you so much. Yeah, this was a paper we were fortunate to work on and led by a postdoc who works with me, Alejandra Perez, who's a fantastic ID doc who helped to put all this together. But really, the big risk factors in ICU patients are those things that are going to let Candida get past the normal barriers. So these are things like intravascular catheters, again, those central lines where provide Candida direct access into the bloodstream, mechanical ventilators, because Candida can cling to the plastic tubing and be really hard to eradicate. Anything that's going into the bloodstream, so aside from IV catheters, ECMO is a big risk factor. Again, the antibiotics, because it kill off the normal, probably because it kills off the normal gut bacteria and allows Candida to overgrow. And then again, just being in the milieu of an ICU room where other people are coming in and potentially transmitting Candida, especially Candida auris, from other patients who might be colonized. So really all of these things make the ICU, unfortunately, sort of a perfect setup for Candida infections. And then again, these patients who are really high risk and the patients who are at highest risk of getting it are the patients who are most likely to have bad outcomes from these infections.
And one of the biggest challenges with managing Candida infection in the ICU is the diagnosis. We usually find out or confirm the diagnosis probably later than we would like to in terms of initiating aggressive and time-sensitive treatment. Could we go over the different buckets of tools we have available as clinicians to make a diagnosis of a Candida infection? And I think the risk factors is a great place to start because in these patients, we should be thinking, could a Candida infection be part of what I'm seeing as the patients evolve? What are some of the clinical signs that we would be looking for Candida infection?
Yeah, I think that's really a great point and a great segue. Candida infections present exactly like sepsis from bacterial infections. So it can be really hard to know upfront with what you're dealing with. And as I mentioned at the outset, it's pretty common, but not common enough that we're going to be starting empiric antifungals on every patient with what looks like sepsis. Of course, every patient with sepsis is going to get antibiotics to treat bacterial infection, but not every patient with sepsis is going to get empiric antifungals to treat disseminated Candida infection unless you're really thinking about it. So it can be really hard. It can be really hard to treat appropriately before we get definitive diagnosis. And there are a lot of problems with definitive diagnosis that I'll get to in just a minute. So the symptoms are, again, essentially indistinguishable from disseminated or severe bacterial infection. So it can be really hard to distinguish just based on symptoms. I think kind of what I was taught in ID fellowship and kind of the classic teaching is that these are patients who might have high fevers after a few days of antibiotics. And that's certainly true. But patients with severe Candida infections can present just like severe bacterial infections in terms of septic shock, high fevers, looking really unwell at the outset. So this can present fulminantly right from the start and not just be kind of the thing that you're left thinking about after 3 or 4 days where you're not sure what's going on. So you need to be thinking about this more at the outset. I think the key thing that's going to help you think about this from the start is thinking about those risk factors we talked about up front. Again, if patients have already been on antibiotics for a while, if they've already been in the ICU for a while, if they have invasive lines and catheters, these are all risk factors. TPN, of course, I haven't mentioned yet, but that's a big risk factor for candidemia. Surgical patients with intra-abdominal abscesses, all of these things are things that should make you consider whether a patient who looks pretty sick could have a disseminated Candida infection. Unfortunately, we don't have any great ways to diagnose candidemia early. So in the early phases of treatment, it really just relies on clinical gestalt to think about candidemia and think about whether we should be treating it before we get definitive diagnosis. But of course, as you're starting to treat, then you're also going to be sending your diagnostic tests. Still, the gold standard for diagnosing Candida bloodstream infections are blood cultures. Sergio, as you mentioned, these can sometimes take a few days to result. Candida do grow on our standard bacterial blood cultures, so you don't need to send the special fungal blood cultures, but they do grow a little bit slower. So it might take more like a day or 2 or 3 for Candida to show up on our routine blood cultures. So in that time, you really want to have been thinking about it so you're not waiting 2 or 3 days to be giving patients appropriate therapy. So blood cultures, again, are kind of gold standard. The sensitivity of blood cultures might not be as high as we would like. I don't think there's we kind of know the exact answer, but some studies have estimated that these might only be 50% sensitive for candidemia. So what else are we going to use? There are other markers of potential fungal infection, one of which is the beta-D-glucan test, or the Fungitel is the brand name. This has been, folks have tried to use this to diagnose candidemia early. It might be a reasonable adjunct test, but there are many false positives and even some false negatives, so it's not the perfect test. Of course, if a patient has an abscess or a focus of Candida infection and they need source control, for example, they need IR drainage of an abscess, then you're going to want to send those cultures, of course, to see if there's Candida growing in there. There was another test called the T2 Candida panel that was pretty sensitive and specific for Candida early, but unfortunately, this one is now off the market. It wasn't that widely adopted due to cost. And then there are also some clinical risk scores for thinking about whether someone could have Candida. These were kind of developed around 20 years ago or so now. They have pretty high negative predictive value. So if someone doesn't score high on these tests, then they probably don't have invasive candidiasis. If they score high, it's hard to tell whether they do or don't. These scores involve things that we're routinely thinking about, I think, such as TPN, dialysis, surgery, for example. So they just sort of back up your clinical gestalt as to whether a patient might have candidemia or not. So I guess just to summarize, these are hard to diagnose. They're common, but not so common that we're going to be treating patients empirically all of the time. So it's really important to think about these up front and consider starting empiric antifungals as we're sending off all these diagnostic tests.
Excellent. I wanted to touch on 2 aspects of the diagnosis and ask you if you could go a little bit deeper. So in terms of clinical signs, obviously we are talking specifically about 2 categories of invasive candidiasis, which is candidemia associated most of the time in our patients with central line or other types of access, and invasive intra-abdominal candidiasis. Are there any signs on physical exam that the intensivist or the critical care clinician should be looking when they examine their patients? I do believe that we can have a whole discussion on the value of the physical exam, but it's important for us to look and touch our patients when they're in the unit,
yes,
especially when they're intubated. Could you give us any insight of what sometimes you see and your ID hat lights up and you say, okay, this might be a problem?
Yeah, it's a great question. I mean, I think the short answer is these are impossible, as far as I can tell, to distinguish upfront from bacterial infection. So when if you see someone who has septic shock and you're not sure why, I'd recommend doing the same things that everyone's going to be doing when they're considering septic shock for their bacterial infections. So if this patient already has a line, then you want to look at the line for any potential signs of infection. Those would be things like erythema, pus coming out of the line, purulence around the line, fluctuance. Of course, if the line has any of those things, then it's going to be highly concerning, but most of our CLABSIs aren't going to present with those signs or symptoms, so that can be really hard. You certainly want to get a good abdominal exam, especially in someone who is immunocompromised or someone who has just had a abdominal surgery. If there's any concern for intra-abdominal infection, then that would make you concerned for this. But in terms of distinguishing Candida from bacteria, I don't think there's anything really on exam that's going to help you do that. So that's where kind of thinking about the patient and thinking about their risk factors is going to hopefully tip you off to thinking about Candida and starting the appropriate antifungals. But I'll admit this is really hard. We don't really know empirically who should get antifungals and who shouldn't. That's things we're hoping to work on. I think things like machine learning could potentially help us identify earlier who might need antifungals before we get those definitive diagnostics. But just on our initial exam, it's really hard to know, and your exam should be similar for anyone with septic shock, looking for potential sources of infection. And then if you do find a source, really thinking about early source control. So can you remove that line even before you know exactly what's going on? Or do you need to have the patient go to IR or surgery to deal with the intra-abdominal abscess? So definitely a very, very tough problem. This is tough for bacterial sepsis, and I think Candida sepsis just adds another layer of complexity.
Excellent. And the second question I had, you did mention obviously that the definitive treatment is blood cultures. Are there any, if we have a high suspicion for Candida in one of your ICU patients, are there any tricks or any tips you could recommend to maybe enhance the probability that that culture would be positive?
Yes. So blood cultures should be checked at the outset for anyone who you're thinking has sepsis or disseminated bacterial or disseminated Candida infection. Standard blood culture practices are what we should be doing for any of these. And I think it's certainly helpful to remind the nurses or phlebotomists when they're drawing these, you need to get 2 sets of blood cultures. So each set has an anaerobic and anaerobic bottle, and you need to get, again, 2 different sets, each with 2 bottles, and you need to fill them up to the appropriate amount. So ideally, this is someone who's going to have reasonable venous access, and you can get all of those bottles from different sites, and you can fill them with the required amount of blood. And again, I think this was confusing to me, honestly, for a long time, even as an ID fellow. Candida is a fungus, but you don't need to order the special fungal blood cultures to grow Candida. So for almost all of our ICU patients, we should just be ordering routine blood cultures, and you don't need those special fungal blood cultures. In the routine blood cultures, Candida will grow just fine on those. Excellent.
Let's talk about treatment. And when we talk about antifungal therapy, I know that in your review paper and in other places I've read, a framework that talks about prophylaxis, preemptive treatment, empirical treatment, and targeted treatment. Could we start with explaining those concepts?
Yeah, absolutely. I'm glad you picked up on that in the review paper, and hopefully this will be helpful to folks. I think this whole topic is a little bit confusing, so it's definitely good to spend a few minutes going over this. So just to define terms, prophylaxis is what we use when someone is at risk for infection, but they don't yet have any signs, symptoms, or lab abnormalities that might suggest infection. So there are some patients who are going to be at high enough risk of Candida infection that they should be on prophylaxis. This is usually our patients with hematologic malignancy, chemotherapy, stem cell transplant, for example. So that's not our routine run-of-the-mill ICU patients. So for all comers in the ICU, prophylaxis is not recommended. This is what some of the risk scores that were developed 20 years ago. They tried to identify patients who might be at high enough risk of invasive Candida infections that they would benefit from prophylaxis. Unfortunately, we haven't really been able to identify groups of patients in the ICU, at least, who might benefit from prophylaxis. So that, again, is not recommended for all comers in the ICU. Preemptive therapy is giving patients antifungals if they have some lab test that is abnormal. For example, in our paper, we highlighted patients who have a positive glucan test, giving them preemptive therapy. I guess the thought here is that this is kind of prophylaxis, or there's some subclinical infection, and by giving them antifungals, you can head that off. Again, there's no benefit here, so we don't recommend checking glucan levels to target your preemptive therapy. So then we're getting into really where most of us are spending all of our time, and that's thinking about empirical therapy. And as I've mentioned a few times, it's really hard to know which patient should give empirical therapy. And I guess just to be even more specific, empiric is when you're suspecting Candida infection, but you don't yet have it diagnosed. So a common kind of scenario in the ICU is going to be someone comes in sick with septic shock. You have a few potential sources of infection that you're going to be looking for. And you think they might have a Candida infection, and then you're going to start empiric therapy before you know exactly that it is Candida or not. So as I've mentioned, this is really tricky because Candida infections in this setting will look just like bacterial infections. And again, we don't have great ways to predict whether a patient has Candida infection. Hopefully, things like machine learning will help us here to be able to identify patients who might benefit. There have been some large trials that have looked into this. The most well-known is the Empiricus trial, published about 10 years ago or so now, that looked at patients that were at particularly high risk for candidemia, whether adding empiric antifungals before Candida was diagnosed would help. And unfortunately, that didn't pan out in that trial. So there's still work to do to figure out exactly which patients are at high enough risk of candidemia that they should be given empiric antifungals before we know the diagnosis. And then the last category is targeted, and that's once you do have a definitive diagnosis, treating patients at that stage. At that stage, things in some respects become a little bit easier. At least you know specifically which bug you're dealing with, and you can really target your therapy to Candida at that point. But again, a lot of us are going to be spending our time in this empirical phase thinking about which patients need candidemia, how long to treat them for, when we can stop, and that's still a really difficult question.
Excellent. And with the empirical therapy, like you said, that's where most people spend their brain power and their time.
Yes.
It's also extremely important. In bacterial infections, we know that if you look at two patients, let's say with MRSA, septic shock, or severe sepsis, and one got empiric coverage up front, and the other one got the coverage 2 days later when we had a positive blood culture, the outcomes could be quite different.
Yeah.
So picking the right patients who are, and our patients, we're talking about very sick patients, is extremely important, and it can have an impact on their mortality. And I was going to ask you, Max, from your perspective, I guess when I think of the mortality with candidemia, at least, it's high. It's 40% or north, I mean, based on what you read. Is that, my interpretation has always been, it's probably driven first by the protoplasm of the patients who get it are usually sicker patients, right? We don't see somebody come in from home with candidemia unless they have other risk factors, like we could see maybe a strep pneumonia and bacteremia in a young person, right? So it's the people who get it. Also, there's always delays, and that seems to be more of a driver than the actual virulence of the organism. Is that a right way of thinking about this, or doesn't really matter, or you think it's all three?
Yeah, it's a great question. I think the easy answer is that it's probably all three, but certainly I think there are contributions of all. And my own kind of idea is that I certainly agree with you, and I think most of it is driven by the protoplasm of the patients who get this. Patients with cancer, with ESRD on dialysis, or patients with cirrhosis. And then in the ICU, it's more common among patients who have already had to be in the ICU for a few days. So certainly those aren't patients who are going to do well. There have also been at least retrospective studies that tried to look at what we call attributable mortality of candidemia itself. And some studies have put that in the area of maybe 20%. So perhaps, some additional mortality just from getting candidemia on top of how sick these patients are before they develop candidemia. And then the last part of that was delays in therapy. And again, the literature here, I don't think is entirely clear, empiricus trials suggested that it perhaps doesn't matter. There are retrospective studies that have shown that delays in therapy also lead to worse outcomes in patients with candidemia. So I think it's a little bit of all three, but I do agree with you that probably the biggest driver is the patients who are getting this. And then there is some contribution of virulence of the species. So, for this audience, it probably doesn't matter so much, but some species are more virulent than others. Fortunately, it looks like although auris can be multi-drug resistant, it perhaps doesn't have the same virulence factors that lead to severe disease. So there's mostly about the patient, I would say, some about the bug as well, and then some about our delays in treating it appropriately.
Excellent. I would like to go over some of more specifics on clinical types of Candida infection, and if you could expand on what would be your initial therapy when you suspect this, what would be the usual duration, and how do you think about source control in these patients?
Yes, absolutely. So the usual therapy when we're suspecting our invasive Candida infections, and again, just to go over the two types, that's most commonly candidemia, which means Candida bloodstream infection, and invasive candidiasis, which is where it involves a organ, and most commonly that's intra-abdominal candidiasis. So the normal therapy when we're thinking about any of these, when we're giving empirical therapy, is going to be with a drug of the echinocandin class. And those are micafungin, caspofungin, and anadulafungin. They're all relatively interchangeable. They have some differences in dosing, but they all do the same thing. And ultimately, it depends on what's on your hospital formulary as to which one you're going to use. So for empirical therapy, we're almost always going to be using an echinocandin when we are suspecting any type of severe invasive Candida infection. So we'll start there. And then I think once you've started therapy and got in your initial diagnostics rolling, and at the same time, we need to be thinking about source control. So we know this with bacterial infections, and I think it's really the same thing with Candida infections. If you're suspecting a line infection and the patient is very sick, I think we know in Candida that failure to remove a line or intravascular device, if that's the source of infection, is associated with worse outcomes. And again, this is really tricky. Our patients need these lines. They're in there for a reason. So the decision to remove them empirically is often really hard. It's somewhat easier if you have a positive blood culture a few days later. But if the patient's very sick up front and you're suspecting a line infection, you really need to be thinking about removing the line. And best case scenario, I guess you're wrong and it was something else, and you have to put in a different line. But if it is the line source, then the patient might not get better until you remove that line. So that's certainly a really tough clinical decision to think about, sort of empirically removing a line in a patient who might have a line infection. And then if they have intra-abdominal source of infection, then talking to the surgeons and IR about getting that trained will be really important, just as in bacterial infection. And then once the patient has an infection, you need to, in addition to looking for the source, whether that's a line or intra-abdominal, if the infection has spread to the bloodstream, then it can go other places in the body. So this is where you and your ID consultants are going to be looking for disseminated infection and sort of what other organs could this have gone to. And you also might need to consider source control for other organs as well. So for example, if it started with a line, but now it's in the patient's prosthetic knee, then they're not going to get better until they have that prosthetic knee drained or source control tapped. So you need to be considering where else the infection could have gone. And then once you have all of those, then you can start to think about duration of therapy. Most commonly, what we see in the medical ICU, at least, is if it's a line infection and it hasn't gone anywhere else, then we can treat for usually about 2 weeks. If it's an intra-abdominal infection, then duration of therapy really depends on adequacy of source control. And it can be honestly really tricky to convince yourself that you have complete source control in these patients. So oftentimes we'll end up treating for a few weeks and then repeating imaging to make sure we have adequate source control before stopping therapy. If you're really convinced of source control off the bat, then from the Stop It trial, we know that just a few days of therapy after source control is adequate. And honestly, I'd have to look back to see if they included Candida patients in the Stop It trial, but I think the same principle still holds. You probably don't need weeks and weeks of therapy if the patient has an intra-abdominal infection and has complete source control.
Excellent. What about Candida endocarditis?
Yeah, this is a really, really tricky one. Candida endocarditis can make people really sick, and the patients who get it, on top of our normal Candida infections, they probably also have cardiac devices or prosthetic valves. So these are patients who are really not well, not kind of set up to do well with these severe infections. So the therapy for these, once you've defined that it's a Candida endocarditis, you can use an echinocandin. For that, we often recommend increasing the dose. So for micafungin, instead of our normal 100 milligrams, we go to 150, for example. Oftentimes we'll use amphotericin for these patients, even if it's a susceptible Candida isolate. There's just more, not great data, but potentially more data with amphotericin and more clinical experience. So sometimes patients will require amphotericin for Candida endocarditis, and the treatment will be for 6 weeks. But really here, source control is going to be key. These patients are pretty unlikely to get better with just the antifungals alone. So these are ones who really need to be talking to the surgeons about whether they can do source control procedures. And again, these are the patients who are least likely to be able to tolerate a big open heart surgery, for example. So these are really tough clinical questions. And actually, I'm just thinking about a patient I had a few days ago who had Candida auris tricuspid endocarditis, and she got the cardiologist did an angiovac and thought they debulked her tricuspid valve, and unfortunately the vegetation just grew back. So these are really tricky ones, need to be thinking hard about source control, but even with that, they're often really difficult to manage, and the treatment can be toxic and can last for several weeks.
Max, any comments on intraocular candidiasis or central nervous system candidiasis that would be different than the approach you have outlined for the other conditions?
Yeah, that's actually a great question, and perhaps we didn't make this point quite clear enough in the review article, so thanks for mentioning it. This has honestly been a big point of debate between the ID and ophthalmology societies in the past few years. Once Candida has gotten into the bloodstream, one place we worry that it can go is the eyes. So for any patient with disseminated candidiasis, or excuse me, I should say Candida bloodstream infection or candidemia, you really need to be asking them about any ocular symptoms that could indicate whether it's gone to the eye. How often this happens is probably in the order of like 1 to 5%, but if it does happen, it can be a pretty severe complication. So check with your patients who have Candida in the blood. If they have new eye symptoms, then you need to be concerned that it could have gone to their eye. And then that's, of course, when you would call your ophthalmologist for an ophtho exam. We used to recommend doing this routinely for all patients. At least the ID Society recommended an ophtho exam for all patients with candidemia, regardless even of eye symptoms. The Ophthalmology Society pushed back against that a little bit. So now I think most of us ask our patients about symptoms, and if they have symptoms, we'll recommend an ophtho exam. Of course, many of our patients won't be able to tell us about symptoms. So for those patients, I would still probably recommend an ophtho exam. Again, if they have Candida in the blood and they do have ocular symptoms, or they can't tell you because Candida loves to go to the eye and can cause endophthalmitis. If they do have endophthalmitis, that is another very tricky condition to manage. The key here is that our first line therapy with echinocandins, and again, that's things like micafungin, caspofungin, these drugs get into the bloodstream really well, but they don't penetrate into tissues and especially protected sites like the eye and CNS. So if you have an eye or CNS infection, then you need to use other drugs. For ophthalmologic infections, we recommend often azoles. Those are things like fluconazole or voriconazole. For central nervous system Candida infections, amphotericin with flucytosine are the drugs of choice, so potentially pretty toxic regimens. But again, I think probably the main takeaway here for all ICU docs to know is just consider intraocular candidiasis for patients with Candida in the blood, and perhaps get your ophtho colleagues to see them. And if you are concerned about this complication, talk to your ID docs about it, because the echinocandin drugs don't get well into these sites.
Excellent. Could you give us some therapeutic considerations for Candida auris? You did mention earlier it's a growing problem. It can be multidrug resistant. So we've heard, in some ICUs, a couple of cases. And what should we be thinking in these patients?
Yes, absolutely. So I guess before we get there, I should mention that, again, the empiric therapy we're going to be giving an echinocandin, and then hopefully we find out that, well, hope not for the patient, but for ease of treatment, once we find out that the patient does actually have a Candida infection, the lab will tell you the species of Candida, hopefully. And then most labs, I think these days are doing, antifungal susceptibility testing. So once you have that back, if the patient has a Candida species that's susceptible to something like fluconazole, and they're otherwise doing well and can take PO, you can change them to fluconazole, perhaps to complete the course of therapy. There are some issues with fluconazole. For example, it can prolong QTC, it can cause LFT abnormalities, but assuming things are going well and the bug is susceptible, then you can change from the echinocandin to fluconazole or another azole. Candida auris, as we mentioned, is a problem because it can potentially be drug resistant. About 90% of auris isolates are resistant to fluconazole, so you can't use azoles for them. Probably about 30% or so are resistant to amphotericin. And then fortunately, the rates of resistance to echinocandins are still quite low, in the order of probably about 10 to 20%. So fortunately, we're still usually able to use echinocandins for these, but there are some places and some outbreaks where they've had multi-drug-resistant Candida auris, where they're resistant to all three of these sort of first, second, and third line antifungals. So fortunately, there are a few new antifungals that are coming online. The one that we're all pretty excited about is called fosmanogepix. That seems like still retains activity against Candida auris. There's also been some limited data about combination therapy for Candida auris. For example, adding flucytosine to another regimen could help. This would definitely be something to talk to your ID colleagues about early and be thinking about what else we might need to be ordering or looking into if we're worried that this patient has a very resistant Candida auris isolate. Fortunately, again, still relatively rare, and we're still able to use our first-line antifungal, which is an echinocandin, but potentially could be a growing problem.
Are there any therapeutic drug monitoring considerations? I presume it depends on the drug, but when are adjustments needed with renal, hepatic failure, or obesity?
Yeah, it's a great question. I think a lot of us think that therapeutic drug monitoring, which is where you check drug levels of these things and potentially adjust the dosing or frequency, will be important. We don't have a lot of great clinical data to back this up right now for Candida infections, at least, but hopefully this is something that we'll learn more about in the next 5 or 10 years or so, because I think it's certainly likely to be important. For renal and hepatic failure, let me take renal failure first. Fortunately, the echinocandins are all dosed pretty similarly, so we don't have to worry too much about renal failure. For hepatic failure, I think the main concern there is our azoles can contribute to hepatic failure. So that's definitely a time when you would want to think about switching the azoles. Obesity, some of us will increase the dose of echinocandins, especially for a resistant or potentially resistant Candida isolate. So that's something to talk to your ICU pharmacists and ID colleagues and ID pharmacists about. So just keep this in mind that potentially we might need to think about targeting a little higher dose for our obese patients. And again, hopefully we'll have more concrete data and evidence on this in the next little bit, because this could be a way we can optimize therapy for these patients, but I just don't think we know quite enough yet to recommend this routinely.
Excellent. You talked about some of the new antifungals, but before we finish this therapeutic section, could you comment on Candida in the urine and in the respiratory secretions? We commonly see this in the ICU. I still think it's an area of confusion and overtreatment, and just want to hear it from the expert. What should we be doing?
Yes, so this was another area that I'm glad you liked the review, and I wish we had focused on this a little bit more. So this is probably the most common time that we talk about Candida in the ICU, is when it's isolated from a urine culture or a sputum culture that we've sent working up infection. So again, Candida lives, especially Candida auris, lives on all of us in our GI tracts and potentially on our skin. And when we give antibiotics and patients have catheters, Candida can grow, and it can grow into these sites like the lungs and the bladder potentially. So I'm sure it's there. Fortunately, Candida doesn't cause infections in these sites. So you don't have to worry about treating it. So again, if you see Candida in the urine or the sputum, you do not have to treat it. Just so no one, gets mad at me. Of course, there's been a case report, I'm sure, of each, but let's just say 99.99% of the time, you do not treat Candida if you see it in a urine or respiratory secretion. That said, it does mean these patients are probably at higher risk of getting Candida infections than patients who don't have this colonization. And we know this from the risk scores that I talked about a few sections ago. So having Candida in these sites probably means that they have Candida living on their skin, close to the catheter. It's probably more in their gut and, just waiting to burst out of that surgical anastomosis when it unfortunately ruptures. So if you see Candida in the urine or the sputum, don't worry about treating it. But if the patient does get sick in a few days and you're not sure what bug is causing their sepsis, this would be a patient who I would think pretty hard about starting empiric antifungals before we know exactly what's going on, because we know that having Candida colonization at other sites is a risk factor for subsequent Candida infection. Again, because these patients are at high risk of Candida infections and they have Candida essentially growing on their body, and it's from there it can crawl into the places we don't want it to get, such as their bloodstream.
That's an important distinction. As a risk factor, we should pay attention, but they don't usually indicate that we should be treating based on that finding alone. And my understanding, Max, is that a lot of the prediction scores include this type of colonization as risk factors, or as gives you points for that, right?
Yes, everything you just said, I totally agree with.
So as we close, Max, in terms of a summary, could you share with us some pearls and pitfalls to avoid with Candida infections in the ICU?
Yes, of course. So I think one really important thing is the thing we just mentioned that I won't belabor again, but just Candida in the urine and respiratory secretion. So that's number one. Number two, I think, is good standard sort of prevention of these infections. And that's the standard things we do to hopefully liberate our patients from the ICU. So take out the central line when you can, take out the urinary catheter when you can, stop unnecessary antibiotics. All of these things that are just good standard ICU care are going to help prevent these infections. Number three, I think, is that the empiric therapy that we've spent a lot of time talking about. I really think this is a tricky thing. This is hard for ID docs like me who think about Candida all the time. I don't know how often I'm correct in predicting whether a patient has a Candida infection if it looks like they have sepsis, but I'm sure the number is quite low. So we need better tools here to think about who should and shouldn't get Candida infections before you're able to definitively diagnose it, which can take some time. So hopefully there will be more and better tools coming online, such as potentially machine learning approaches that I mentioned, that will help us at least kind of clue us in to who we might need to be thinking about Candida infections before we know definitively. And then I think once you think they have a Candida infection, or you're more sure they do in kind of that definitive phase, think really hard about source control and where else this infection could have spread, so that we can appropriately get source control everywhere it needs to be, and then continuing antifungals, hopefully for no longer than they need to be continued.
Excellent. Well, Max, you've been on the podcast before, so you know how we end. We like to ask a couple of questions unrelated to the clinical topic. Would that be okay?
Yeah, of course.
So we talked about books last time, but it's been almost more than 5 years. So I'm going to ask you, have any new books influenced you significantly, or is there a new book that you might be gifting often to other people?
Yeah, we were joking about this before, but last time was about a year into the pandemic, and all of my books were related to viral pandemic infections. I guess I was kind of into that theme back then. I'm into slightly more escapist books now. I don't know if you want to call it that, but I've had a few close mentors recommend a book called 4,000 Weeks about time management, and I've really liked that one. And it's probably more than time management, just about sort of getting down to the things that are important and trying to not focus too much on the other stuff. So I think that's been sort of a helpful book, and hopefully a defining theme in this, still early part of my career when I'm trying to figure out exactly what I want to focus on.
Absolutely. And that's a wonderful book, and we'll link it in the show notes. And the way I would summarize that book and others that are similar is, if you don't set your priorities, somebody will set them for you, right?
Yeah, exactly.
So be very intentional about knowing what's important for you and creating the space for that. Awesome. Yes. What music album or playlist would you want with you in a prolonged isolation period, deserted island, or like, since we mentioned pandemics, if a pandemic were to isolate us again?
Well, Sergio, we're both here in Texas, and I'm not a native Texan, but I do love Texas. And since I moved here a few years ago, I've been getting more into country and sort of Americana music. So one artist that I've really liked is Charlie Crockett. He's from South Texas. So sort of Americana, folk, Charlie Crockett style country is what I would take with me these days.
Excellent. And I have to say that despite living in Texas, that is not my cup of tea. No. In music. I'm really into jazz, but the reason why I ask these questions is because I'm always interested in listening to new things, reading new books. So I will definitely give Charlie Crockett a listen the next couple of days.
I think he's pretty approachable. I still wouldn't say I love all types of country music, but I think he's really excellent and worth a listen.
Will do. Could you share with us something you changed your mind about over the last couple of years?
Yeah, I guess on that theme, this is a great question, but I think living in Houston, I've really changed my mind about, I wasn't sure what I would think about Houston when I moved here a few years ago, but I've really loved it. It's a fantastic place with all sorts of types of people and a lot of stuff to do. It's really sort of livable, approachable place, and the folks here are great. So I really, really like it here, and I'm happy I'm here.
Well, happy to hear that. And I can't call myself a native Houstonian, but they say that you're not from where you're born, but where you love. And clearly, I love living in Houston. I have found a lot of interesting things to do. Very, very diverse in many aspects. And I'm not very fond of cold weather, so that has been an extra plus.
Yes, I totally agree. And I have a slight variation on that. You're not from where you're born. I've heard it's not where you were born, but it's where your wife's mother lives. So that's why I'm in Houston.
Absolutely. That always is a big factor.
Exactly. But I still like it. And it's been great being close to family.
Awesome. So as we close, is there anything you would want every listener to know? It could be a quote or a closing thought.
Yeah, thanks for asking this question. And I guess, just coming off service, I think probably other folks know this, but I guess this is mostly for me, as much as anyone else, but just how rewarding it is to talk to families of our patients. I think it's easy to go through the day and sort of check the boxes and deal with the medical stuff. But, sometimes a few days into service, I'm sort of just kind of going along and doing that. And then I talk to a few families and it really kind of gives me a little more energy. So I hope I remember that the first or second day I'm on service every time. And I'm sure everyone else knows that. But it's just always helpful for me to remind myself.
Absolutely. And along those lines, this is something I got right before we started the podcast. One of our team members from one of our programs outside of Texas shared that they had an event with family members, and that the wife of one of our patients who had been in the ICU for a long time gave a very eloquent speech. And at the end, she looked at our team, and I'm going to read what she wrote, or what she said was, to the intensivist: when they are overwhelmed, you are steady. When they are afraid, you are calm. When they don't understand, you explain. When they are exhausted, you carry the weight with them. You don't just treat an infection or illness, you fight for his life and their future. You make impossible decisions with skill and compassion. You work long hours that they may never see. You stand in the gap between crisis and hope. I thought was beautiful and so powerful, coming from a family member, and just a reminder of the impact our work has on the life of others. So I'm happy you brought that up. This is something I was reading before we started, and I just felt, immediately, why not share? So Max, thank you so much for sharing your time and expertise with us. We definitely, there's no two without a three. So we will definitely have you back soon to talk about critical care topics, and especially those that interface with the world of infectious disease. Thank you.
Thanks so much for having me. And yeah, thanks for sharing that quote. That was really fantastic. And I certainly hope to live up to that.
Thank you for listening to Critical Matters, a sound podcast. Make sure to subscribe to Critical Matters on Apple or Google Podcasts and share with your network. Sound's transforming the way critical care is provided in hospitals across the country. To learn more, visit www.soundphysicians.com.